Everybody. So as Karthik mentioned, I'll be talking about REVIVED-BCIS today. Thank you all for joining us. So this trial, the main clinical question the study sought to answer is whether or not there's an added benefit for PCI over optimal medical therapy alone in reducing event-free survival in patients with ischemic cardiomyopathy. So before discussing the trial itself and the results, I'll briefly just go over, data showing the significance of this disease, the morbidity and mortality it causes, and then some of the prior data regarding revascularization and ischemic cardiomyopathy. So as we all know, the prevalence of heart failure is increasing. This graph from the AHA policy statement in 2013 shows that there's going to be a continued increase in prevalence all the way to 2030. This is based on current epidemiologic models using current risk factors in the US population. And we all know that it has a very high morbidity and mortality, and that CAD is the biggest risk factor for heart failure. The figure on the left shows data looking at almost 40,000 patients from the Get With the Guidelines Heart Failure Registry, which shows regardless of ejection fraction, although our focus is obviously going to be low EF today, the mortality at 5 years is as high as 75%. And the graph on the right from the NHANES epidemiologic follow-up study of over 10,000 patients shows that more than 60% of the heart failure that we see is likely attributable to coronary artery disease. So it remains the major risk factor for heart failure. And there's a significant burden of CAD. So with CAD in patients who have heart failure with reduced ejection fraction, the presence of CAD causes worse outcomes. In this prospective analysis of about 600 patients hospitalized for the first time around 2000 and followed for up to 10 years, it shows that CAD was an independent predictor for all-cause and cardiovascular death, and it has a powerful prognostic impact in adjusted hazard with an adjusted hazard ratio of 1.6 for all-cause death and 2.0 for cardiovascular death. And this is really seen early on, and this continues throughout the follow-up period with a continued separation in the graphs. So the main mechanisms behind ischemic cardiomyopathy, as we know, are the two main mechanisms that are proposed is one, myocardial stunning, and the second one is myocardial hibernation. So with stunning shown here at the top, the process of reversible systolic dysfunction following an episode of transient ischemia. So for example, you come in with an MI, you have rapid loss of coronary blood flow. This then results in immediate impairment of myocardial contractile function. The blood flow here is shown in the blue line and the myocardial function in the red. And then when you resolve, you open up the blockage, you have quick restoration of blood flow, and then you gradually expect over days to weeks to see an improvement in the stunned myocardium back to hopefully normal function. In the second figure here, which shows myocardial hibernation, this kind of refers to a more chronic state of matched reduction in coronary blood flow and myocardial contraction. So this is an adaptive process where the heart function reduces due to a chronically reduced state. And the hope is with restoration of blood flow after successful revascularization, whether PCI or CABG, this hibernating myocardium recovers its systolic function. And this is the main patient population that will be kind of discussed today. So the question of whether or not we should revascularize has been asked multiple times over the last 2 decades. None of the trials really looked specifically at PCI alone or PCI versus CABG in any randomized way. And REVIVED, as we'll discuss very shortly, is the only real trial that delved into whether or not PCI is helpful in a randomized fashion. The main trial in this space that we all know of is STICH, which looked at CABG versus optimal medical therapy, CABG plus optimal medical therapy versus optimal medical therapy alone in patients with ischemic cardiomyopathy with an EF less than 35 and coronary artery disease that's suitable for revascularization. The primary outcome was the rate of death from any cause, and the major secondary outcomes included rate of death from cardiovascular causes and death from any cause or hospitalization as a composite for cardiovascular disease. And the follow-up period for the STICH trial was about 6 years. Their primary outcome, there was no significant difference between medical therapy alone versus medical therapy plus CABG, and that's for all-cause mortality. But the patients that were assigned to CABG did have lower rates of death from cardiovascular disease or death or hospitalization for cardiovascular causes, as shown in figures A or B. The STICH extension trial reported longer-term mortality data from STICH. At a median follow-up of approximately 10 years, 59% of patients assigned to CABG died versus 66% in the medical group, with a hazard ratio of 0.84, and this was statistically significant. The death from cardiovascular causes and several pre-specified composite endpoints also occurred less often in the CABG group. There is, however, a critical balance between safety and efficacy when examining the impact of age on the treatment effect. So when they looked at subgroup analyses, the long-term survival benefit was not apparent, was most apparent in the younger population and was not apparent in those older than 60 years of age. And that's probably because there was a higher peri-procedural mortality and morbidity in these older patients. What about evidence for revascularization in PCI? So the next two studies I'm going to present are both retrospective studies using registry data. So in this first one from the New York State PCI and cardiothoracic surgery registries, looking at a little over 4,500 patients. Patients were included if they had multivessel disease, which was defined as severe stenosis of greater than 70% in at least 2 major epicardial coronaries. And they had LV dysfunction defined as an EF of less than 35 and either underwent PCI with everolimus stents or underwent isolated CABG. They excluded patients that had severe left main disease because the thought was they're more likely to get CABG. Anyone that had prior surgery was excluded. They did not include anyone with ACS in the last 24 hours. And anyone that was revascularized within the last year was also excluded. And no patients that were in a shock state were included in the study. And their finding was among patients with multivessel disease and severe LV systolic dysfunction, PCI with everolimus stent had comparable long-term survival when compared to CABG. Despite propensity matching, obviously, to account for baseline imbalances between these two groups, doesn't account for unmeasured confounders. And we all know this is an issue with mostly all trials with retrospective design. In the second trial, which kind of was a very similar design, used a multi-center registry based in Ontario, Canada, which also included patients that had multivessel disease and EF less than 35% presumed to have ischemic cardiomyopathy. They excluded ACS, prior CABG, or shock patients. And this patient population was a little bit higher at 12,000 patients, reportedly the largest patient population kind of looking at this question. And they found that in patients with ischemic cardiomyopathy, coronary artery bypass grafting was associated with a greater long-term survival compared with PCI. So what do the guidelines tell us? The AHA and ACC guideline, they recommend CABG as a class 1 recommendation in patients with ischemic cardiomyopathy And they have no recommendation for PCI, and it's kind of left to the clinicians to decide when PCI use is appropriate. And the ESC guidelines gives CABG a class 1 for this patient population, and PCI a 2A recommendation if complete revascularization is achieved or achievable. And there's been clearly a lack of randomized data in this space looking specifically at PCI, which brings us to REVIVED. So the study hypothesis was that revascularization by PCI plus optimal medical therapy will improve event-free survival and left ventricular dysfunction in patients with severe ischemic dysfunction with an EF of less than 35 compared to optimal medical therapy alone. This was a prospective, multi-center, randomized, open-label trial. It was funded by the National Institute for Health and Care Research, and they recruited 700 patients at 40 centers in the UK over a seven-year period. Patients were eligible for enrollment if they had an LVEF less than 35, as assessed by echo or cardiac MRI. They had extensive coronary artery disease defined by the British Cardiovascular Intervention Society Jeopardy score, which we'll go over in the next slide. And the cutoff was greater than 6. This is a scale of 0 to 12, 0 being low and 12 being a high burden of coronary disease, and anything greater than 6 was included. And they also wanted a demonstration of viability in at least 4 dysfunctional myocardial segments that were amenable to revascularization. And this was the majority of viability in this study, about 70%, was done by cardiac MRI. And they excluded patients if they had acute coronary syndromes within the past week. If their presentation was ACS or acute decompensated heart failure, they were excluded. Patients with sustained arrhythmias were excluded, anyone with severe angina, and anyone who had severe renal disease. So just coming back.
So yes, and just go back to the previous slide.
Yeah.
Can you explain what was the thought process behind viability, or at least what you gleaned from?
Yeah, so I think to them, the question of viability remained unanswered even after the sub-analysis from STICH. It was never really answered in a randomized fashion. And the thought process of the prior slide I showed of the mechanisms of ischemia, the trialist thought was that it is essential to revascularize an area that they thought was viable to give us a more likely positive result for this trial. So they wanted to, in my mind, they wanted to give PCI the better chance that we're revascularizing viable myocardium. And the thought process of the pathophysiology to them was that these segments are viable, and hibernating, when you do PCI, you'll likely improve function.
Yeah, so basically, one reason is to, satisfy the naysayers, because if they don't do viability, later people would come up and say that, there's some suggestion that viability study may have helped, so we don't know about the results. And I think the second thing is also, when we use viability, we use it differently when we revascularize with CABG as opposed to PCI. And PCI, you could sort of just revascularize, the areas that are viable. But in CABG, I think, the usual practice is if there's viability, you still do like a full CABG. I don't think even in STICH, they did like targeted revascularization, even if there was, viability in some areas versus the other. So PCI, offers that tailored approach to Revasc.
Yeah. So this score, personally, I was not really familiar with the British Cardiovascular Intervention Society Jeopardy score. And this is, again, used to define how extensive the CAD or coronary artery disease is.
Yeah. There was go back to the previous slide one more second. So, although it says acute, so it says acute decompensated heart failure, but these people, could still be hospitalized for heart failure before that, right? And I think a lot of them did have prior hospitalizations for heart failure.
Yeah, this is the index, like within the last, yeah. But they obviously, some of them were New York Heart Association 3 or above, but we're talking about the index, at the index procedure, they were not in heart. Yeah.
Okay, go ahead.
So this score, again, anything greater than 6 is considered significant. There was a small study that I found that did correlate this with a score of greater than 6 with a cause of the cardiomyopathy as being ischemic. And they kind of looked at MRI as the gold standard for defining the etiology of a cardiomyopathy. And when patients had a BCIS score greater than 6, the test had a 76% sensitivity and 97% specificity for ischemia being the cause. So I'm just gonna, take a random patient and just kind of go over this to see how this score is calculated. So if we see this table on the right, if we look at step 1, it asks about left main disease. Let's assume that that's absent for the sake of this patient, and go to step 2, which asks about proximal LAD disease, assuming the patient does have a greater than 70% stenosis. In that case, it asks us to go to step 5, which asks about dominance. Let's assume that the RCA is dominant. We then go to row 6, and let's assume that there is greater than 70% prox RCA disease. So far we've accumulated a total of 10 points already, 6 for the LAD and 4 for the RCA. And then we get, we go through the rows and get asked about circ disease, assuming there's no disease in the circ. We go to row 14, which asks us if there's been a prior CABG or not. And if we say that there's not been a prior CABG, we go to row 21, which is the final row. And this would tell us that this patient had, again, a total score of 10, and a patient like this would be included in the study. So patients were randomly assigned in a 1-to-1 ratio to a strategy of PCI versus optimal medical therapy. It was PCI plus optimal medical therapy versus optimal medical therapy alone. Optimal medical therapy here refers to individually adjusted pharmacologic and device therapy for heart failure. Medical therapy here was initiated before enrollment and customized according to the patient's individual needs throughout the trial by a heart failure specialist at the recruiting center. In the PCI group, the protocol required that revascularization be attempted on all diseased proximal coronary artery vessels and subtending the areas of viable myocardium. And the extent of revascularization was actually calculated to try to get, complete revascularization in the majority of patients. In total, 347 patients were randomized to the treatment arm and 353 to the control arm with a median follow-up of 41 months. And they had, a very good follow-up rate in both arms.
Yes, and did you show the outcomes already, like the primary and secondary outcomes?
Right here.
Oh, okay. I missed that. Okay.
No, I didn't show it yet. This is.
Okay.
Yeah. So the primary composite outcome was death from any cause or hospitalization for heart failure over a minimum follow-up period of 24 months. The major secondary outcomes were left ventricular function at 6 and 12 months, again measured by echo by the Echo Core Lab. There were components of the primary outcome: death from cardiovascular causes, quality of life scores, use of ICD, acute MIs, unplanned revascularization were also among the secondary outcomes measured. The investigators recruited 700 patients based on power analysis. They thought that this number of patients would provide them greater than 85% power to detect a hazard ratio of 0.7 if there were 300 events. The trial, as we see in the majority of randomized trials, was an intention to treat analysis to avoid, any effects of dropout or crossover. this is our baseline table, and the baseline characteristics show that our population is around 70, so older age, male predominant and white predominant population. A high percentage of patients were diabetic smokers, and about 50% of the population had prior myocardial infarctions. I tried to kind of see what their definition for prior MI is, and it looked like it was adjudicated by the recruiting center, so whatever their definition of a prior myocardial infarct was. The majority of patients, I think these are the most notable things in this population, were class 1 or 2 New York Heart Association functional class. And the majority of them also had no anginal symptoms at all. And almost half of the population only had 2 vessel CAD. When we look at the procedural details in the PCI arm, the majority of patients had drug-eluting stents implanted. The median number of vessels and lesions treated were 2, and they had a 98% success rate at treating 1 lesion. However, the total amount of, or the revascularization index or complete revascularization in this study was 71%. So their median or mean British BCIS Jeopardy score was 9.3 before, and then mean was 2.7 after the procedure. Again, this corresponded with a 71% complete revascularization index. And this is our primary outcome, which again was death from any cause or hospitalization for heart failure. And this occurred in—
So Yasin, can you comment on the choice of the primary outcome of death from any cause as opposed to cardiovascular death? So
yeah.
As well, they used all-cause death.
Pardon me.
In the STICHES trial as well, the outcome was all-cause death.
Yeah, this was,
But in bypass, often, patients, especially, with the initial increased mortality, a lot of the mechanisms are different, right? Like respiratory failure and, all kinds of stuff that happen after a bypass surgery. In PCI, when there's not so much of this, baggage of the initial procedure,
I think that the choice was made because this is ultimately what you care about, mortality, regardless of the cause of the mortality, is what would be, the most important. For me, it was, I think, just because they wanted to recruit a reasonable number of patients, they had a composite of the primary outcome of death from any cause or hospitalizations for heart failure, rather than like the STICH trial being just a single primary outcome.
Right. But with that hypothesis, then it should be like all-cause hospitalization, right? Why just heart failure? Because there we're sort of focusing on cardiac, but for the mortality, not. I wonder if anybody else has a comment on that.
Yeah, I think it's a difficult endpoint to achieve because, as you showed nicely in your first slide, Yasin, the mortality over 5 years for any reason for these patients is extremely high. So if 75% of people are going to die over 5 years, or was it 71.7, it's tough because that gets diluted out because there's so many causes of death in these older folks. The KCCQ will be interesting because, some people will say, well, if I'm going to die in 5 years, I want to have a better quality of life and less time in the hospital. This is something that's come up a lot recently with chemotherapy, that, while we prolong life for 3 or 4 months, the quality of life or the time free of hospital stay isn't really that different sometimes.
And Karthik, I wonder if it's more just practical, a death you don't have to adjudicate, like if someone dies, okay, they're dead, but you don't necessarily have to give an autopsy report or anything like that. And then the heart failure hospitalization, you can wait till the coding's done and then screen it by ICD-10 code. So I think they're trying to be, as you started there.
Yeah, so I think the modality of death, of cardiovascular death, there's always a little bit of subjectiveness in assigning that as well. All right, go ahead.
So again, the primary outcome, there was no difference throughout, and we see that the curves basically are perfectly aligned from the beginning. And then when we look at secondary outcomes, there were no significant differences in the components of the primary and no significant differences in acute MI. I think it is important to note that they had included peri-procedural and spontaneous MIs under the umbrella of acute myocardial infarction. Obviously, the non-PCI group did not have any peri-procedural MI, but if we look at the spontaneous MI, there's almost a double amount of spontaneous MI in the optimal medical therapy group. And this, then when you look at the unplanned revascularization, you do see a significant difference with a threefold increase in the rates of unplanned revascularization in the optimal medical therapy group, which I thought was important to know. The subgroup analysis shows that the treatment effect across all pre-specified subgroups was the same. There was no benefit for the primary outcome when you looked at higher functional New York Heart Association class, those with left main disease, people with higher BCIS Jeopardy scores, or even lower ejection fractions than 30. The major secondary outcomes were LVEF and quality of life outcomes. There were no differences in the left ventricular ejection fraction between the two groups. However, there was a prompt improvement in health-related quality of life after PCI, which parallels what we've seen in multiple prior trials of PCI. And this should not be discounted. You see that first of all, these patients had limited symptoms from the get-go. They were a pretty asymptomatic population, with the majority of them having New York Heart Association 1 or 2, and the majority of them having very little angina. So the fact that you had an improvement at all is significant. And this improvement is sustained with PCI, which was also seen after revascularization in the STICHES trial. And the narrow difference between the two groups over time is expected because subsequent revascularization was performed to a greater extent in the optimal medical therapy group, which obviously dilutes this a little bit. But the optimal medical therapy group, a good amount of them, as I showed prior, did have unplanned revascularizations, potentially for symptoms.
So go back to the slide. So there's some early improvements, as you pointed out, in quality of life, but later OMT catches up. It's not so much that the early benefit of PCI, then goes away and then, the curve sort of goes down. It sort of is sustained, right? And then it's more like the OMT is caught up later. So it's not a decrement of the early benefit.
No, but
that's how sort of OMT works as well, right? It takes time to work, and that's, I think, an important observation here as well.
Yeah. I mean, some of the OMT group did get revascularizations though over time within the study period. So it's a little bit tricky to know whether they eventually, their quality of life improved because they eventually did get PCI, some of that group, or because, like you had mentioned, the optimal medical therapy just takes time to kick in. The investigators reported a few limitations, and firstly, it's open label design. The investigators believe that would only affect the patient-reported outcomes because both the primary outcome and the LVEF were assessed in a blinded fashion. So all hospitalizations for heart failure were adjudicated in a blinded fashion by an independent events committee, and researchers adjudicating and analyzing the trial outcomes were also blinded to the treatment assignment. The core lab, looking at the Echocardiographs were blinded to treatment assignment, as well as timing of the studies in relation to randomization. The second main point they bring up is that, this group of patients had no angina, the majority of them, and had lower New York Heart Association functional class. So this, the results of this trial can't really be extrapolated to patients presenting with severe angina or those with lower quality of life because of their heart failure or heart failure symptoms. And thirdly, they were, the total number of events in the study, they had anticipated 300 events for a power of 85%, but they got only 263 total events. But because the hazard ratio was 0.99 of the primary outcome, they didn't really feel like there was any type 2 error or issues with the trial results. And the takeaway and the study conclusion here is that at 41 months follow-up in patients with ischemic cardiomyopathy and LVEF less than 35% with viable myocardium, PCI, in addition to optimal medical therapy, did not result in a reduction of death or hospitalization from heart failure. And this was how the study was presented. Basically, in patients with ischemic cardiomyopathy, there was no benefit to PCI.
Can you go back to the previous slide? Yes.
Directed medical therapy. Yeah.
What other things would you add in that second point in patients with? So obviously, well, I guess you meant LVEF less than 35 there, but severe LV dysfunction, extensive CAD, some degree of viability. But an important point is also that all these people are essentially CABG rejects, right? Although that's not an inclusion criteria or something. I think Dr. Pereira himself, I think, had sort of said that most of these patients are rejected by CABG, right? So these are not people who could have got CABG otherwise.
Right. Yes.
That's an important point. And in STICH, it's all people who could have got CABG, right? So that's one of the primary reasons why the age difference is also there. And a lot of these folks are super old because of that.
Yes, absolutely.
So, how would PCI, pan out against OMT or CABG in a CABG eligible population? This trial sort of does not answer that.
Yeah. No, absolutely. And I think a lot of these points that you're bringing up were, brought up in the editorial piece that was published with this trial. And I want to highlight a few points that were brought up. So it is pretty essential for the investigators to show in more detail, and I think this will be, coming up in later analyses from REVIVE, but the anatomical location and extent of coronary artery disease. So to me and to the writer of this editorial, it seemed like there may be a discrepancy between how much LV dysfunction there is, where all patients had an EF less than 35%, but half of this patient population had 2-vessel CAD. And we all know that it is, very difficult kind of assessing whether the CAD you're seeing is just a bystander or is really the cause of the cardiomyopathy. And I think it's not necessarily always very clear just because of this discrepancy. The preliminary analysis regarding the completeness of revascularization and the myocardial Jeopardy were also just performed based on the site reports rather than systemic and objective scrutiny of the angiograms. And when the analysis is complete, this may change. And there was
Yassine, what way do you think it would change? Like this, a similar comment was made about Orbita, but then they put all the angiograms in the supplementary index, and the disease was worse than anyone thought it would be. So, I read the editorial, and I understand that like the core lab analysis is pending, but my sense is that it's going to end up being worse than anybody thinks it is.
Yeah, and I thought it was a little one-sided to the editorial. With regard to the low burden of disease that you point out of half the patients having 2-vessel disease, I was looking at STICH as well, and about 40% had 2-vessel disease. So, I don't think it's very different in that sense. Certainly, the Revasc, the folks, the IGUS bandwagon or like how much IOS was used, and was this optimal PCI? A lot of those results will come out later when they do sub-analysis. But then, importantly, this is real world practice, right? So, this is how the intervention will pan out when applied to the real world. So I think all those things, the sub-analysis will not really change things too much. And I think, PCI did come short again for stable coronary disease. It has come short before, and non-LV dysfunction population, and this is an LV dysfunction population. So
yeah, I'm a little worried about the comment that most of these patients were not CABG eligible, because to me that means they typically don't have good surgical targets, which from an interventional perspective means their distal vessels are small with diffuse runoff. And that really ups the ante. And I know, when Yusuf and I are looking at patients for high-risk interventions that might be in this group, if they're largely asymptomatic with bad runoff, we treat those patients medically. We only intervene if they have refractory symptoms of angina or heart failure. And I think, this really didn't answer a question for me.
And the medical therapy is a good point as well. These folks, and I think they had a heart failure specialist at each of the sites, and a lot of new therapies have come out, right? For example, SGLT2 inhibitors and stuff during the course of this trial, and they sort of reacted to the evidence, and the OMT was actually excellent in both the arms in this study, compared to STICH, I would say, but they were limited in what was available at that time. So it was definitely a win for OMT. A lot of folks had CRT as well, in both the arms. So that also dilutes the effect.
But I would, Yasin, so let's assume, and this is how I want to come up with the idea or conclusion. Let's assume that the trial, they did everything they could. Let's assume what they did is good, meaning, was disease is bad, EF was bad, viability was there. How would you interpret that without looking at the limitations and what could have been? Let's assume they did everything they could, in the real world. What does it tell you?
Yeah, this to me tells me that patients who are stable, so non-ACS, not hospitalized for severe heart failure or recurrent heart failure admissions, have no angina, you should treat medically, and not do any PCI. But I don't think this is the majority of the patient population that we, to be honest, end up seeing. We a lot of the time see patients who may have a type 2 MI from their heart failure exacerbation that are being admitted, and we have to decide on whether or not to revascularize. This patient population was excluded.
So would you be revascularizing in the midst of a heart failure exacerbation? I'm not really sure. Right.
Yeah, but a lot of times we have to answer the question of whether or not this patient that comes in with recurrent heart failure admissions who has extensive coronary artery disease and a low EF will benefit from revascularization. And this trial does not answer this question for us. It doesn't answer whether or not someone who's coming in with recurrent symptoms will benefit or not, because these patients, I don't think a good amount of them were included, with the majority of patients having New York Heart Association 1 or 2 in a total population of 700 patients.
So do you think that the disease that they've seen was not functional? Meaning, again, it goes back to the flow. Should you open up or you should not open up an artery? So do you think if they added any physiologic study, would it change?
No, I don't think the disease is not functional. I think the patients are stable. I think the majority of the patients are stable in this patient population. So medical management is great. And like Karthik mentioned, that people were very appropriately medically managed, and that should be the goal. However, if patients are having symptoms and still failing medical management, I don't know that this trial for me has answered the question that revascularization with PCI will not be helpful. If they're, again, non-CABG candidates for whatever reason, especially in the older populations where we know in STICH there was kind of lack of benefit in that older group. I think we're
But-
going to be seeing more and
but
more of these
that-
patients.
Yeah, but that logic throw out all the FFR, right? So it doesn't matter when somebody comes in and they feel okay, but if you do an FFR and it's abnormal, you shouldn't do anything, right? You should let it be.
If the no, of course, if the FFR is normal, then that's not significant coronary disease.
And in multivessel disease, FFR, at least versus CABG, has not seemed to improve things, right? Whether FFR, PCI guided by FFR versus PCI without FFR in LV dysfunction, certainly we wouldn't know. I don't think that question is answered, but for multivessel disease, at least the recent data of FFR has not been great, right, from FAME-3.
Yeah, so I think to me it goes back to how you define then, cardiomyopathy in the setting of something that you think it's ischemic. Is viability not a good study? Or I mean, if you believe that your coronary disease is appropriately defined, again, is either the coronary disease is not appropriately defined, or how you define viability is not also it doesn't have the appropriate definition.
Yeah, but at least the fact that they did viability, stacks it to show a PCI benefit, right? And that's part of the reason why they built it in as well. That if there was any population that would benefit, one would think that it would be a somebody with viability. So I think that would have shown a PCI effect. There are also other comments that folks had about the extent of follow-up, because in CABG, there was an earlier harm, as expected from a surgery, but then later things caught up. So maybe long-term follow-up of this cohort may show something different, but then this cohort is also 70 years old. So how long of a follow-up is practical in this cohort is also unclear. And most of the patients that we see in practice are CABG rejects, right? At least for multivessel PCI. So that way it's very practical in terms of patient flow. So, I was disappointed by this trial overall.
I have two questions. One for Hussain, one for the group. So Hussain, I had some technical difficulties. I missed kind of some of the end of your presentation. Was there any change in EF between the two groups? Did they look at that at all? There was no change in EF.
There was not.
So I mean, did EF go up in both groups, or stay the same in both groups, or went down in both groups? No change. So
it looked like it may have went up a little bit, but overall stayed in the under 35 range. So no significant improvement in either group.
And then I get my second question. I guess it's really a comment. I think based on our practice, the way I see everyone practicing within our group, I mean, we're all a fairly conservative bunch. I don't think we're going around doing, a lot of angioplasty in these patients without clear symptoms. I've always found that these studies, they're geared towards interventionalists at the time of complication, but the people who really need to read them are non-interventional colleagues, because they're the ones that are pressuring us to do a lot of these interventions that we don't really feel comfortable doing. We don't really think are going to benefit patients. So, I don't know if these articles are reviewed in any sort of non-invasive journal club, but I think that would be very useful, because we're the ones that get the heat. And there's pretty good solid evidence that, doing at this point, as Karthik said, that, angioplasty for relatively asymptomatic patients doesn't do very much good for if anything, other than expose them to the risk of the procedure. We've certainly seen our fair share of bad outcomes, unfortunately.
So quick question for I guess Hussain and everyone else. So one of the things that have come up with this study is the paucity of angina. The NYHA was low, but also angina scores were patients had good angina scores, so the angina burden was low in the population. Do we expect that to be a significant player in how the study turned out if we had patients with more burden of angina would you think that would, that would matter in terms of the outcome?
I think in terms of the quality of life outcomes, potentially you would have seen a more prominent separation and a more persistent separation. But I think, just looking at other trials that kind of looked at it, there's not going to be I would not expect a mortality benefit all of a sudden just because the population had more severe angina. I think, quality of life would probably have been different. I don't know what others think.
All right, so let me be the devil advocate, because this patient is gonna come tomorrow, right? Somebody comes in and they had a drop in EF. His EF is now 35. The symptoms are not much, and you see 2 lesions, one in the proximal LAD, one in the proximal RCA. Doable with stents. What would you do now after this trial, or anything? Would you change anything?
I mean, I think this trial kind of suggests that it's a good place to stop and put the patient on medical therapy and then reassess in a month and see how they're doing. If they still have heart failure symptoms,
if they're ineligible for capping,
bring them back and do PCI. I mean, I agree with Sam to some degree that we're conservative as a group, but often I think if we see a cardiomyopathy and angiographically severe lesions, we proceed with intervention because that's historically been the standard of care. But this trial challenges that.
Right. So,
Constant, in your case though, is it if it's an acute drop in EF, right? I mean, you can make the argument that this is more of an acute presentation. I mean,
right. So after this,
I think you're talking more of the chronic.
Yeah, after this trial, I'm not sure. What I mean. For 30, 40 years, basically the flow hypothesis. You have flow, you have drop in EF, you have to open up, and this. Again, at least raises the question of, is this a, I hate to use this term, but a paradigm shift, or however you want to call it, or is the viability, the way we look at it, not, not the right way to look at viability. I think they thought about it and they excluded the fact that they should have or could have a cardiomyopathy from something else. I mean, it's England. Who knows? Maybe everybody drinks and they have an alcoholic cardiomyopathy, and it doesn't matter. But I don't know that.
No, and it looks like there will be an assessment specifically of the cardiac MRIs to kind of look at scar burden and kind of correlate it more. But I think the majority of these patients were actually ischemic cardiomyopathy, more likely in my opinion, rather than this is bystander disease. Again, the patients that we see inpatient, the problem is you can't really tell whether, with the troponin elevations in these patients and the new acute symptoms, it's very difficult to say, I'm not going to revascularize based on this trial data, because I don't think a lot of that patient population, I don't think they were included in this trial. So it's hard to just, medically manage when you have treatable disease.
And, viability is also demonstrate viability in 4 dysfunctional myocardial segments. So, one would imagine that these folks would have much more dysfunctional segments than 4. And then viability doesn't mean that it's always scar, right? A lot of these segments could just be ischemic too. So I'm interested to see how many people had scar and how much that burden was. I would say like more than half of the population would really not have extensive scars, right? That's what I've seen in experience. How many folks with 35% EF that we're revascularizing have large scars?
Yeah, I don't know. I feel like, anytime we have a trial like this, that's, nice. And I mean, they thought about a lot of things. We kind of find the arguments against it, and we kind of proceed and continue to do what we've been doing. I don't know. But the trial, I think they did everything they could to kind of show us that you know, chronic stable disease, even with, you know, cardiomyopathy. I don't know if we're doing the right thing, revascularizing.
I don't think it's wrong, but I think, you know, we should appreciate that the mortality benefit is from medical therapy.
Yeah, the fact that the EF in both groups, you know, improved, although marginally, but in a similar fashion, is also kind of surprising. You know, I think you restore flow to a, you know, an ischemic or an area that, you know, ischemic but viable, you should have recovery in myocyte function. But, you know, medical therapy did just as well in both groups. There'll probably be some heterogeneity and treatment effect study down the line to tease out, you know, who benefited more from PCI in terms of LVF recovery. But overall, you know, it's pretty surprising that it didn't really impact LVEF recovery that much with restoration of flow.
Do people think we're doing a lot of these cases at the moment? Kind of stable cardiomyopathy, PCI?
Yeah, I mean, so look, their definition of stable, I just want to add to what Hussain said, is even if they had heart failure on an admission, as long as they were 3 days out from their decompensation, then they would have qualified. And I do think we do a decent number of those patients who come down as inpatients, came to the CC with heart failure, had a newly reduced EF, had multivessel disease, they get sent down for revascularization before they go home. I mean, I'm happy to be wrong about that, but it seems to happen quite often.
It's also a source of a lot of outpatient referrals. Someone will get an echo and the EF will be, you know, 30 or 35%, and they'll say, prior echo 3 years ago was 60%. The patient may only have vague symptoms of dyspnea, and you know, you end up doing a diagnostic procedure. Then the next step obviously is FFR. So I think some of those patients do get referred as outpatients as well.
There's also time for a STICH 2 maybe now with so much improvement in OMT. I don't know if STICH trial results would be the same now.
You know, I was surprised when I looked at, you know, I wanted to look at that STICH trial, you know, medical therapy was very good. Much better than I had thought it would be, to be honest. Because I just wanted to see what the patient populations looked like. And, you know, most of them were on beta blockers, MRAs, ACE ARBs. So not very different from this patient population.
In REVIVED, how many were on SGLT2 inhibitors?
That it was very low. I can't.
I don't think
a big difference, it looks like here, right? So not sure how much you could attribute it to that.
I didn't put it in because it was low, like in that teens, if I remember correctly, the SGLT2.
Yeah, you have to remember how long ago they started that trial.
Exactly,
Yeah,
2013.
It's not like they started it a year ago.
That's all I have for you guys. If there are any other comments.
Yeah, no, that was a great presentation. Thanks, Yasin. The audience is a bit quiet compared to other, you know, trials. People are probably, you know, more digesting the results. And
no, I thought you did a great job. Yes,
Yes.
great job on a complicated topic.
Thank you.
Before we go, one comment for the fellows, not a comment, a request. If you could continue to make sure that the cardiac rehab orders are entered for all of your revascularization patients.